Welcome back, fellow mitochondriacs, to another episode of Cancer as a Mitochondrial Metabolic Disease. Most tumors exist in a low oxygen environment, a condition known as tumor hypoxia, which is associated with treatment failure and poor outcomes. Most people have heard of hyperbaric oxygen, HBOT, and that it might help in fighting cancer. But what happens if we increase the oxygen level without the pressure? In this video, we'll break down normobaric hyperoxia and what the research shows about its potential effects on tumor biology and treatment response. So without further ado, let's get into it. So I'm going to start this video out by telling a bit of a story. So I remember about a year and a half ago, I had a consultation with someone, and that someone, if you're watching, knows who you are. And they asked me a question in the middle of the consult that I didn't know the answer to. And they asked me basically like, if I put my loved one on just normal oxygen, like an oxygen machine, an oxygen concentrator, not at pressure because we can't afford it. We can't get to it. I can't remember exactly what the scenario was around it. And will it help her? And I did not know the answer to the question. I said, I don't know. I mean, it kind of makes sense that it would, but I don't know the answer to that. And it always bugged me that some of these metabolic interventions are so expensive and so difficult to find in your local environment. And if you can find them, they're an arm and a leg in terms of pricing. And so that question lingered with me about the idea of using oxygen therapy without pressure. And I'm just thinking how logistically that would solve so many problems, because that would make hyperoxia a much more accessible intervention that someone could add to their regimen without a crazy amount of cost. And so I went down this rabbit hole of normobaric hyperoxia, and I wanted to share it, what I learned, in a couple of videos. This is going to be part one of this. And then part two is actually going to be even more shocking, at least from my perspective. So without further ado, let's just keep moving forward. So the first paper I pulled was from Med Hypotheses in April of 2011. The title was called The Normobaric Oxygen Paradox, a novel way to administer oxygen as an adjuvant treatment for cancer, ? And what it says here in the abstract is the normobaric oxygen paradox is a dual mechanism by which oxygen regulates the expression of the hypoxia-inducible factor HIF-1 alpha. And the HIF-1 alpha depending gene regulation is responsible for many different genetic expressions, including EPO, which is erythropoietin, and VEGF, vascular endothelial growth factor, that are usually expressed in parallel. First, VEGF underexpression could decrease tumor angiogenesis, leading to a decrease in tumor growth or even apoptosis in cancer cells. Second, induction of EPO expression can provide cytoprotection, although this could be deleterious for cancer cells while helping non-malignant cells, or at least neuro, brain, and cardiac heart cells, to be protected from side effects of chemotherapy. Eventually, HIF induction could boost immune response by inflammatory cells, increasing their anti-tumor activity. So basically I pulled this because this was just kind of like just being thought of as, could this even be a thing? And so I'm going to advance our understanding by pulling this paper from May of 2018, and it was titled Normobaric Hyperoxia Inhibits the Progression of Lung Cancer by Inducing Apoptosis. And I highlighted some things in the abstract here. It says, following a tail vein injection with Lewis lung carcinoma cells, so they inoculated these mice with this lung cancer model, right? And then what they did was they exposed them to 24 hours of normobaric oxygen and hyperoxia, this cycle, for 2 weeks. And then in addition, this A549 lung cancer cells were incubated in normobaric hyperoxia chamber for 24-hour period. And as a result, the size and number of tumors in the lungs decreased significantly with exposure to normobaric hyperoxia in the mouse model. And it later says that the study demonstrated that the role of normobaric hyperoxia in inhibiting lung cancer, normal tissues and cells showed no significant hyperoxic damage in our experimental settings. The anti-tumor effects of normobaric hyperoxia may be due to the increased reactive oxygen species activity and apoptosis, which is related to the mitogen activated protein kinase pathway, MAPK pathway. Impact statement, normobaric hyperoxia is a feasible therapy for cancer with low complication rate. Although NBO, normobaric oxygen, may be beneficial in cancer treatment, very few studies have been conducted. Thus, the evidence is thin. This is the first study to clearly demonstrate morphological changes in lung cancer with normobaric oxygen exposure to investigate the underlying mechanisms both in vivo and in vitro. And basically what they did was they put these mice in cages, like a glass cage that was exposed to, when they wanted the mice to be exposed to oxygen, 95% oxygen. And there's other times when they would, these 24-hour cycles where they would put them under normal conditions. So let's see what actually happens to the mice that had oxygen versus the controls. So the average number of control mice tumors after injection with these cancer cells was about, let's say, 21. And if it was the mice who got oxygen at 95%, they had less than half of the amount of tumors. And then when they looked at actual tumor volumes, the tumor volume was about 50 for the control mice. And if the mouse got oxygen therapy, just oxygen therapy, this is not with chemo, this is not with radiation, this is oxygen only, then the tumor radically shrank down to about 5 to 10%. So I found this to be extremely interesting. And so it then kind of like looked at, well, what could be going on, right? And I think that the hypothesis always with hyperoxia, whether it be HBOT or ozone or other hyperoxic therapies, is that you're increasing reactive oxygen species compared to baseline, right? So you see here that at baseline, and I believe this is going to be a normal lung tissue is what I believe this BEAS2B is. So you're seeing that they're relatively similar in terms of reactive oxygen species level, but as soon as you add the oxygen, right, oxygen after 24 hours, you see how the ROS goes up meagerly in the normal cells, but it more than doubles in the cancer cells. And then you'll see here also in the normal cells that when you give hyperoxia for 24 hours, it does lower normal cells' glutathione levels, but look what it does to the cancer cells, much more so than. Here's glutathione for the cancer cells. Here's glutathione for the hyperoxia cancer cells. And then this is malonaldehyde, which is a breakdown product of damaged oxidized DNA. It's an oxidative stress marker. So you see here that at 24 hours of oxygen, the normal cells barely had any more than their controls, whereas there's already a much higher amount in cancer cells because there's just higher oxidative stress in cancer cells. And then when they added oxygen, they saw more in that group as well. And this makes a lot of sense because we looked at this paper before. I'm not going to read the entire thing, but this paper was basically highlighting that ROS, or reactive oxygen species, as you can imagine, relies upon oxygen to be created. So if we're giving extra amounts of oxygen, it would make sense that there's more ROS that is formed. And so there's actually been a couple of studies looking specifically at that, right? So they did oxidative stress response kinetics after 60 minutes of either 30% FiO2, which is still higher than ambient oxygen, right? We're breathing 21, or 100% normobaric hyperoxia. And I'm just going to go to the graphic here because I think it makes more sense. So here's baseline, right? Here's all of us that are breathing 21% at 0 hours, right? And then with 30%, you see a significant rise. You do see higher rise at 8 hours after just 1 hour. Remember, this is 1 hour of breathing oxygen, right? So the effects are delayed for 2 days. So my point is that you're higher than baseline for both even 30% and 100%, which means that there's probably benefit to even mild amounts of hyperoxia, 30%. Time will tell what that cutoff will be, what that time will be, but there's probably benefit. The hyperoxia under 100% is better, and I can hypothesize maybe why it's not as good as it could be. We can talk about that. And we can see here that the 8-OHGG, which is another version, is kind of a different version of this malonaldehyde, MDA. It's another marker of oxidative stress. Goes up, it kind of peaks at about 2 hours, it starts to come down, but it still takes about 48 hours to go back to baseline. So you're getting the benefits of hyperoxia without pressure. That's clear. The question is it comparable? I think that's to be determined. This stuff is so complex. And that's why I'm in the process of building more structured resources around this very topic as well as others, because understanding the concepts is one thing, but applying and implementing them is another thing completely. For those who need more support, I have links below for one-on-one consultations and the new upcoming Press Pulse Implementation Lab community. So the next paper I'm going to pull was published in February of 2020 and is titled Hyperoxia Alters Ultrastructure and Induces Apoptosis in Leukemia Cell Lines. And I specifically wanted to pull this paper because there are a couple different groups of people who have cancer who believe that they are not susceptible to what everybody else is susceptible to. one of which is prostate cancer. For whatever reason, prostate cancer, they think they can burn fat for fuel and they, whatever. And then people who have non-solid tumors like leukemias also think that the metabolic therapies are not going to be effective for them. And this is a paper that I pulled because I really wanted to show that that was not the case. So it says oxygenation conditions are crucial for growth and tumor progression. Recent data suggests a decrease in cancer cell proliferation occurring after exposure to normobaric hyperoxia. Those changes are associated with fractal dimension. The purpose of this research was to study the impact of hyperoxia on apoptosis and morphology of leukemia cell lines. Two hematopoietic lymphoid cell lines, a T lymphoblastoid line, GERCAT, and B cell lymphoid line, CCRF-SB, were tested under conditions of normobaric hyperoxia, greater than 60% FiO2, for 18 hours, and compared to the standard group, which was 21%. We tested for apoptosis using caspase-3 assays. Caspases are the proteins that are activated under apoptosis. Cell morphology was evaluated by cytospin, microphotography after coloration, and analysis by a fractal dimension calculation software. Our results showed that exposure of cell lines to transient normobaric hyperoxia induced apoptosis, elevated caspase-3, as well as significant and precocious modification in cell complexity, as highlighted by increased fractal dimensions in both cell lines. These features are associated with changes in structure, pyknotic nuclei, and apoptosis recorded by microscopic analysis. Such morphological alterations could be due to several molecular mechanisms and rearrangements in the cancer cells, leading to cell cycle inhibition and apoptosis, as shown by caspase-3 activity. T cells seem less resistant to hyperoxia than B cells. So I pulled this graphic here from the paper. This is one of the graphics, and this is on the T cell line. This is the GERCAT cell line. And you see here that at just 18 hours of hyperoxia, the amount of pycnosis, which is a changes in the nucleus, it looks like, is about maybe 500 to 600% higher. And the amount of apoptosis going on at baseline is 0. And at 18 hours of 60% FiO2, we see a massive increase of 0.2, which is, given it's 0, it's like an infinite amount, but it's still a huge amount compared to baseline. So what are we actually observing by this hyperoxia conditions? We're observing the benefits of what you would get if you have increased dissolved oxygen in plasma. And we looked at a table very similar to this in the last video when we were kind of comparing or introducing hyperoxia, but also slightly comparing normobaric hyperoxia versus hyperbaric hyperoxia, right? And so what we're seeing here is we're seeing, 10x, 8 to 10x amounts of oxygen at higher pressures. Some of these studies are done at 30% FiO2, 60% FiO2, which is going to be much lower than this. But my point is that's enough in these studies, at least in some of these in vitro models. The in vivo models did use a higher amount, 95% oxygen. And you're going to see here in this next paper that they also are going to use a little bit higher oxygen as well. So the next paper was published in November of 2018, Hyperoxygenation as a therapeutic supplement for treatment of triple-negative breast cancer. And they observed that triple-negative breast cancer tumors became severely hypoxic. No shocker there. In this case, there were less than 4 millimeters of mercury within a week of growing, and then responded poorly to administration respiratory hyperoxygenation of 100% to mitigate hypoxia. So what they were doing was they were saying, okay, if we just give oxygen once, does that make any difference at all? And they didn't see a whole lot. But then they said, however, periodic oxygenation with supplemental oxygen, and they used 100% oxygen for just 60 minutes a day for 21 days, showed a significant inhibitory effect on tumor volume when compared to the control. And then in combination with supplemental oxygen and paclitaxel and radiation therapy led to a significant reduction in tumor growth when compared to just radiation alone. The therapeutic enhancement by supplemental oxygen is possibly attributed to increase in tumor oxygenation with paclitaxel at the same time as radiation therapy. So what we got here is we got tumor volume. So there's kind of two things looking the same thing. So let's look at the beginning and the end, probably the easiest way to do it. So we see here at 0, they're all setting out at the same amount, right? And then the control group who got neither oxygen nor chemo nor radiation, nothing like that, right? Grew to 1,000 millimeters cubed. Then if they got chemo only, they were 20% decreased from that. And then if they got chemo plus paclitaxel, they were 40% decrease after 21 days. Pretty unbelievable. The next study is titled Combination of Carboplatin and intermittent normobaric hyperoxia synergistically suppresses this benzo A pyrene induced lung cancer. And it was published in May of 2018. And basically what they did was they had a group that got nothing, right? They had a group that got only oxygen. They had a group that got oxygen plus the drug, and they got a group that got just the drug. So they had a group that had nothing. They had a group that got drug only. They had a group that had oxygen only. And then they had another group, the last group, group 4, which had drug plus oxygen. And in this particular study, they did use higher amounts of oxygen, 95%, and they used it for just 3 hours a day. So it was not these 24 hours a day models that we've seen in the past. And we want to see, does this 95% oxygen at just a couple hours a day, does it make a difference of whether this carboplatin does better or not, right? Let's take a look at the results because I thought this was pretty interesting. So here's the amount of tumors, right? 21 tumors if they just let it go, right? At the end of this period. And this was 28 weeks. So let me just quickly go over. They only did this for a period of 7 weeks. They started the experiment at week 21 and then they ended at week 28. So this would be at week 21 and then the end of week 28, right? So if we just let it go at 28 weeks, we see that we had 21 tumors and the average tumor size was about, 15 or so millimeters cubed, right? Now, what happens when they gave only the drug? Well, we saw a significant decrease in tumors, right? What happens when we gave only oxygen? We saw the exact same thing as the chemotherapy. Whoa, right? And then they gave oxygen plus chemo, and you had a 50% or more reduction in the amount of tumors at the end of those weeks. Then let's look at volume. So here's the 15 or so millimeters cubed we started with if you got nothing, right? And then if they got chemo, you did see the tumor shrink significantly, right? More than 50% shrinkage. If they got oxygen only, it also shrank about 50% because this is more than 50% of the starting, right? And then if they got both, they were even smaller. I think what was most shocking to me about this, it's already been kind of implied that hyperoxia would make sense, that it would synergize with chemo or radiation or whatever they were doing in that particular study, right? However, I think what makes it more interesting is that hyperoxia alone made it performed almost as well as chemotherapy in these mice. And then if you added them, of course, you're going to expect a synergy between those two. Pretty awesome. Now, let's take a look at 8-OHGG again. This is the oxidative stress marker of DNA damage, right? So here's a control, very little, right? Or whatever the baseline was, right? Let's say 8. If we just gave drug, you see it went up to about 11, maybe 12. If we just gave oxygen, it more than doubled, because that's darn near 20. I'd say that's probably 19 maybe. Started at less than 10. So it doubled the amount of oxidative damage just by giving 95% oxygen 3 hours a day, right? And then if they combine them, we saw even higher amounts. And that's explaining, at least partially explaining, the synergy between the two, the drug and the oxygen. And it also explains the standalone between the oxygen and the reactive oxygen species, right? So pretty awesome. And so, if you remember back from the video that we did last time, it said there was no evidence to support normobaric hyperoxia. What is this? This is evidence, right? It may not be the evidence we want to the degree that we need it or want it to be the standard of care, but it's evidence. And it's pretty powerful evidence, as a matter of fact, because this is not the end of it. So this paper is what I'm going to end on. It was an old paper from 1990, and it was titled Effective Normobaric Oxygen on Tumor Radiosensitivity, Fractionation Studies. And it says here that the sensitizing ability of 100% normobaric oxygen was investigated in a mouse mammary carcinoma or breast cancer mouse model using a variety of fractionated regimens. Both regrowth delay and local control were used as assays of tumor response. With both assays, there was a similar and significant increase in radiosensitivity for all fractionated schedules. Enhancement ratios ranged from 1.24 to 1.45, with the highest being observed in the 30 fraction schedule given in an overall time of 6 weeks. Thus, in a mouse breast cancer model, normobaric oxygen is far more efficient radiosensitizer in fractionated treatments than in oxygen mimic compounds misonidazole, an oxygen effect being observed at doses per fraction as low as 1.8 GY. These results suggest strongly that normobaric gases could play an important role in the clinical management of tumors where hypoxia may limit the outcome of radiotherapy. And that is exactly what we would expect, right? If the average tumor is at 10, And there is a big portion of the tumor, the hypoxic core or the poorly vascularized region, which has much lower than 10 millimeters of mercury. If we give normobaric hyperoxia before radiation therapy, it would make sense that it improves. And we've known it for 100 years, and we've seen it as early as the 1990s with studies being done. The question is, what is being done clinically today with this information? Absolutely nothing. And I think that's what needs to change. If you like videos like this, please like, share, and subscribe. And until next time.